Hey, what up all my two doctors and doctresses? Welcome to another video at the Tooth Factory. Today's topic, pituitary and thyroid hormones. This is dental pharmacology, so we'll stick to the pharmacology aspect and not get into the pathology aspect as much, but we will touch on it slightly in the end of the lecture. Moving on to the table of contents, we have the overview of neuroendocrine system. Basically, we just need to know where all of these endocrine hormones come from. Then comes hypothalamus and anterior pituitary, hypothalamus being where the signals generate from, and anterior pituitary where the hormones get secreted from. And then, of course, the hormones themselves. We have adrenocorticotropic, also known as corticotropin, somatotropins, also known as growth hormones. We will definitely look into these in more detail. For now, it's just important to look at the names. And then, of course, the somatostatins, which is growth hormone inhibiting hormone, and gonadotropin releasing hormone, as well as gonadotropins themselves, which is FSH and LH, which is follicular stimulating hormone and luteinizing hormone. These are our reproductive hormones. And then, of course, how can we forget the posterior pituitary, where there is oxytocin and vasopressin that get released from the posterior pituitary. And then lastly, we'll take a look at thyroid, a full short note, and then hypo versus hyperthyroidism we'll take a look at. As our new addition to this lecture is the alert screen. We keep looking at this in the past few lectures. You want to keep an eye out for these things. These are important. GH, growth hormones. ACTH, which is, it's essentially adrenocorticotropic hormone, but we'll take a look at how it variates into different functions. And then, of course, THS, which is thyroid stimulating hormone, then thyroid hormone themselves, T3, T4, FSH, LH, we just talked about, CRH, and that, which is corticotropic releasing hormone, and then propylthiouracil, iodine. Now this is going to be pretty fun, guys, so keep an eye out for iodine. Levothyroxine, thyroid storm, Wolff-Chaikoff effect, as well as oxytocin, prolactin, and corticotropins. At the beginning of the lecture, all of these may sound foreign, or, we've learned this back in theory, but it's kind of under the carpet right now. But we'll make sure to keep it fun, light, and you can remember all the concepts again. Here we go. Neuroendocrine system, entirely controlled by the pituitary gland and hypothalamus. So that's good. Two less members to worry about. So hypothalamus, pituitary gland. Hypothalamus is the brain's region that controls the pituitary gland. Perfect. So this is the parent gland. And then this is the pituitary gland, which secretes many different hormones, and some of them affect other glands as well. And one of the most common ones being adrenal. Okay, so we'll take a look at how this gets relayed. Then we have coordination of bodily functions using means of messengers. So essentially hormones are what? They're messengers that control bodily functions. This system is not the same as nervous system. There's a differentiation. See, nervous system is a local communication that uses electric impulses, neurotransmitters, neurons, by the use of neurotransmitters from brain to target organs. Perfect. It's an electrical circuit. However, communication in milliseconds and response last short durations, this is only associated with the nervous system. Whereas the neuroendocrine system releases hormones into the bloodstream itself. So number one difference. Hormones carry messages. So it's not an impulse, it's a message. It's information, guys. Communication is anywhere from seconds to days, and the response can last weeks at a time. So that's the neuroendocrine system. However, both systems can stimulate or inhibit one another, so they're interlinked. Main function of the hypothalamus and the pituitary is to control metabolism, growth, and down here it says reproduction. So let's remember that. Now, We will touch on thyroid gland in this lecture. It affects metabolism. And then we will touch on adrenal glands, although a more detailed version of this lecture will be in our corticosteroids lecture, which is the next lecture in the series. However, it's the inner part right here, the yellow part of the kidney, that helps trigger flight and fight responses. So see how it kind of links to the sympathetic nervous system? So remember from our adrenergic cycles that flight and fight response is the body's automatic, involuntary function of the central nervous system's autonomic nervous system, which is specifically sympathetic. So that's how neuroendocrine is linked with the nervous system. And then, of course, pancreas we talked about in our last diabetic lecture. It regulates sugar in the blood by the means of insulin. And then, of course, the reproductive. This is going to be in our androgen lecture, which is testes and ovaries. It's male sex hormones and female sex hormones. Okay, moving on to important terminologies. Remember, at the beginning of the alert, we came up with a few of these. So just let's find out what they mean, right? ACTH, adrenocorticotropic hormone, corticotropin. CRH, corticotropin releasing hormone. Okay, now I'm going to stop right here and let one thing be clear with us, that whenever there is a RH, that is releasing, that hormone is solely there from hypothalamus to pituitary. That's all there's right here, CRH. It will nowhere else to be found. Why? Because hypothalamus recognizes that, oh, here's my kidney, and kidney says, hey, hypothalamus, I'm gonna need a little bit of ACTH. I need to function a little bit more. Can you produce some? So hypothalamus is like, all right, demand is going to be met with supply. So hypothalamus sends CRH to pituitary, and pituitary is like, uh-oh, I've got an order from hypothalamus. What do I have to do? I have to release some ACTH. Okay, so this concept is the same for every releasing hormone. FSH, follicle stimulating hormone. Now, stimulating hormone. So, adrenocorticotropic hormone, the ACTH right here, is something that affected the target organs, right? It stimulated the target organ. So this also is a type of stimulant, stimulating hormone. So similarly, FSH will become a part of journey from pituitary gland to target organs because it's stimulating. Same thing with GH, growth hormone. It will play a role in this section here. Growth hormone, releasing hormone, where will that play? Right here. Perfect. So that concept is clear, you guys? Amazing. And then there's gonadotropin releasing hormone. This is associated with the FSH and LH, guys. Sorry, up here. So gonadotropin releasing hormone plays a role here. FSH plays a role here. LH plays a role here. Okay, so just remember this. HPT, hypothalamus, pituitary, and target. Releasing hormones, stimulating hormones. Perfect? Awesome. Then there's human chorionic gonadotropin. A lot of pregnant women, especially that are freshly pregnant, so if you've just conceived a baby, and then you start measuring HCG, specifically known as beta HCG, this is a placental hormone. Okay, so placental hormone, it is where when a woman is pregnant, initially in fresh pregnancy, it is low. As the baby starts growing, the placenta starts growing because it needs to meet the blood supply demand of the baby. Therefore, beta HCG goes up. So it's a marker for pregnancy. And then there's HMG, which is human menopausal gonadotropin. You can assume that that has to do with menopause or postmenopausal women. And then IGF, which is insulin-like growth factor, hence it affects Pancreatic activity. Luteinizing hormone, this is very well important in the actual conception of the sexual reproductive system. And then prolactin, this is for lactation. Then there's recombinant human growth hormone. So recombinant means just something that's designed outside of the body through DNA recombinant therapy or technology. When that's done, it's put back into the system via injections, IM or subcutaneous, and then it's delivered to deliver the function in people who have lack of growth hormone naturally. Then there's somatostatins. Somatostatins do the exact opposite. When you have a lot of growth hormone, it works to inhibit growth hormone. And that's why statins exist. Okay? TRH, thyrotropin releasing hormone. So we can tell that it plays a role between hypothalamus and pituitary, thyrotropic releasing hormone. And then, of course, the TSH, which is thyroid stimulating hormone, also known as thyrotropin, which is thyroid stimulating hormone. And can you guess what that target tissue is? It's a gland, thyroid gland. Perfect. Moving on, let's talk about pituitary and hypothalamus. We're moving inside the bottleneck now, a little more specific. It weighs 0.6 grams. Imagine something so light and it creates such a big turbulence in the body, right? Where is it located? It's located at the base of the brain at the bony sella turcica. Very important. It's an exam question. It's like a little dent in the base of the brain. And that dent it's known as sella turcica, the bony sella turcica. And the pituitary gland is residing right here. And right above the pituitary gland, we have the hypothalamus. Okay? It's close to the cavernous sinus and optic chiasma. So optic chiasma is, remember guys, when there's two eyes and then occipital lobe right here at the back. And this is, we're looking at it from the top of the brain, okay? Top of the brain, coronal view, and we're cutting it, slicing it. So optic chiasma is when it kind of X's. So optic nerves, they come out and they X. And then of course they make their way to the occipital lobe to give us vision. That optic chiasma, and of course the anterior cavernous sinus, middle, and then of course the posterior. The cavernous sinus is located right in this section here, and this is where sella turcica is with the pituitary gland. Okay, it's actually in the center of the brain, but just to kind of give us a picture in 2 dimensions. Okay, I'm going to get rid of this from the screen, and here we go. Anatomically, there's 2 lobes. We've heard anterior and posterior, but we need to know that they're also called adenohypophysis. What does that mean? Adeno means any hormones that are released from the anterior pituitary will have at least an ACTH in here, and that is how you remember adeno. Now it doesn't mean it's related, it's just some way of remembering. Anterior adeno ACTH. Hypo means below, and physis, okay? Hypophysis. It's a part of a communication mechanism from hypothalamus to the pituitary, pituitary to the target tissues, and posterior is neurohypophysis. It's just below the brain itself. Okay? Connections. Overlaying hypothalamus. Hormones are carried to anterior pituitary from hypothalamus by hypophyseal portal system. And that's the portal venous system. So hypothalamus will have, remember RH, all the releasing hormones. It will be sent from hypothalamus to the portal, pituitary's portal venous system, also known as hypophyseal portal system. It's bloodstream, and then it links itself into pituitary, where pituitary will begin to do stimulating hormones. So, thyroid stimulating hormones, growth hormones, follicular stimulating hormones, these things, right? And then hormones are carried to the posterior pituitary from hypothalamus again, and by neurosecretory fibers, it is released. Now, why does it say neuro? Because here is a neuron that is activated. That's why we said that the nervous system and the endocrine system are interlinked. Although primary function of the endocrine is via blood vessels, there is some component of neurons as well. And then of course they go to the target tissues. Great. Now let's talk about the actual hormones. So all hormones in this category are peptides. In other words, they're proteins, which bind to a specific receptor at the target tissue and then they act. Very simple concept. So in the anterior pituitary, the hormones are produced, very important, in hypothalamus. And then of course regulated by neuropeptides, which is just messengers. They are labeled as releasing hormone or inhibiting hormones. Releasing hormones will go to the receptor interactions, lead to gene activation, and then of course a synthesis of precursor hormone. In other words, releasing hormones are basically a way of hypothalamus telling pituitary that, hey, do whatever you have to. If you have to do gene activation, go ahead, but make me a precursor hormone, because these precursors then produce hormones themselves. Once all the natural, the generic hormones are out of the question, that's when pharmaceutical uses come into play, where pituitary hormones are either administered IM or SC, which is intramuscularly or subcutaneously. And the GI tract will digest these hormones readily. Therefore, you can't really give it orally. Why would they digest it? Because it's a proteolytic enzyme activity, right? These are proteins. You eat protein, you get digested. That's what it is. GI will digest hormones considering, oh, it's just another dietary peptide, using proteolytic enzymes. Now, 6 hormones that we will talk about in detail, guys. These are all anterior pituitary hormones. Adrenocorticotropic hormones, also known as corticotropins, growth hormones, which are also known as somatotropins, growth hormone inhibiting hormone, somatostatins, gonadotropin releasing hormone, gonadotropins, and of course prolactin. Perfect. Awesome. So let's take a look at this diagram to understand a little better. Hypothalamus sends a releasing hormone to pituitary's anterior lobe. Anterior lobe functions on a multiversatile scale. Growth hormone is released into the liver and insulin-like growth factors are produced, IGF. And when these are gone into the bloodstream to the target tissues, they act to grow all muscles, all fat tissues, everything. It just grows everything. And then there's ACTH, adrenocorticotropic hormone. It goes to the adrenal cortex. Where is adrenal cortex? It's on the kidney. It produces glucocorticoids, mineralocorticoids, androgens, and these are the next 2 lectures. So we'll talk about these in the detailed lectures later. Another anterior pituitary hormone can go to is TSH, which is thyroid gland, and then of course it produces thyroxine, which is the thyroid hormone that affects the target organs. FSH, LH, these are reproductive hormones and hence they would go to the ovaries. Estrogen and progesterone are also produced from that process as well. And then in the male, there's LH. LH goes to testes and produces testosterone. Now we will talk about all of these androgens in detail, sex hormones in the detail in later. Prolactin is for lactation and it goes to the breast as target tissue. Okay, so finally we're into the specifics. Adrenocorticotropic hormone, also known as corticotropin. Corticotropin releasing hormone function is that it creates synthesis and release of a peptide known as pro-opiomelanocortin. Why is this important? This is what activates the production of ACTH. Okay, so here, let me hold this thought for a second. If we go back, do we remember that a releasing hormone goes to the anterior pituitary, acts on the receptors, The receptors then activate gene activation, and then we have a precursor. That's exactly what this is. A releasing hormone has come from hypothalamus to the anterior lobe and has produced a precursor, hence the word pro. It is opiomelanocortin. This now stimulates the ACTH from the anterior pituitary gland and then into the bloodstreams. Now, I'm going step by step, not because this is an extremely important topic in dental pharmacology. It's really not that important as far as exams are concerned or daily activity as a dentist is concerned. But this is important just to know to formulate your basis for dental pharmacology. So stick with me. The stories are great. The slides are very interactive. Hopefully you have fun learning. Adrenocorticotropic hormone is a product of CRH process. We learned that. Normally released from pituitary in pulses with a diurnal rhythm, daytime hormone. So there's two rhythms, right? There's diurnal, there's nocturnal. Now, this is daytime. Of course, your daytime hormones are different than your nighttime hormones because our body functions are different at night. So in the daytime, basically when you wake up, it's got to be the highest, right? And of course, the lowest in the late evening. Why? Because it's function. What does it do? Well, we'll find out at the end that when ACTH reaches the adrenal gland, what it does. Stress and diurnal rhythms will stimulate ACTH release. So morning stress, early morning stress, such as you're running late for work or school, that causes the release of ACTH. It's a positive feedback. And then cortisol inhibits ACTH release. Cortisol rises in stress as well. Okay, so this is new. What is this? Well, let's take a look here. In ACTH, adrenal gland is the target tissue. In it, in the cortex. Why is that so important? Well, because this dark brown area is known as the medulla. The yellow part is known as the cortex. ACTH goes to the cortex. Adrenocortical. Okay? What happens there? Another chemical reaction in the cortex. Cholesterol turns into pregenolone. Pregenolone turns into progesterone and then into cortisol. Cortisol goes into the bloodstream and cortisol gives three actions. Number one, anti-inflammatory actions. Great. Why? Because it's more released under stress. Stress could be exercise. Stress could be infection. Inflammation is a stress, therefore anti-inflammatory action. Then there's increased gluconeogenesis, meaning produces more newer sugar from the liver, increases protein breakdown, and it actually becomes metabolic, right, in a way. So cortisol is an important hormone that is associated with diurnal system as well, and it's the end of the thread from the CRH family. Pharmacological applications of the synthetic versions of these drugs are what? Well, replacement therapy for hormone deficiency. So if you're missing ACTH, administer ACTH. If you're missing cortisol, take cortisol. Antagonistic therapy for diseases causing excess hormones. If there's excess hormones and you give more cortisol, so if there's, for example, excess cortisol in the body, how do you reduce cortisol? Give more cortisol. When you give more cortisol, you give a negative feedback to the hypothalamus and say, oh, I've got enough cortisol. Please stop producing cortisol. And that's how one way is to decrease the excess of these hormones. And lastly, diagnostic for endocrine abnormalities. It's a diagnostic method because if there's an abnormality associated with cortisol and you administer cortisol, it will show you that this is the disease. So it's a diagnostic tool. Okay, let's talk about the basics in pharmacology. Mechanism of action. ACTH binds to adrenal cortex, activates G-coupled proteins. So these are processes. G-coupled, they look like kind of cylindrical, and they're arranged in a 5-tube pattern. And then, of course, they're intermingled with different amino acids and receptor sites and proteins, messengers that take it below. Okay, so ACTH binds here on the adrenal cortex, establishes a rate-limiting step in adrenocorticosteroid synthetic pathway. All it means is that it monitors how much goes in, how much gets used into the system, how much more we need, and so on. It is where cholesterol turns into pregnenolone, terminating in synthesis and release of both adrenocorticosteroids, cortisol, and androgen are associated. So two things are the end of the thread from CRH. We talked about cortisol. Androgen is a new lecture as well. Therapeutic uses of the ACTH. We have synthetic adrenocorticosteroids are used as a diagnostic tool for differentiating between primary adrenal insufficiency and secondary adrenal insufficiency. Okay, so what is that now? Primary adrenal insufficiency is the lack of function of the adrenal cortex. Therefore, ACTH may be there, but cortisol will never come out, and therefore there is no action. This is primary adrenal insufficiency, known as Addison's disease, where ACTH is fine, but because of adrenal atrophy, in other words, reduction in the size of the gland, it functions less. Secondary adrenal insufficiency is an actual lack of ACTH. So what if the pituitary gland didn't send enough ACTH? No matter how functional adrenal gland is, it's not going to do anything. Therefore, these synthetic mentioned above are known as cosintropins. Cosintropins, remember that. Cosintropins are the synthetic versions of ACTH and other hormones in the same family. ACTH is also used in the treatment of something known as a West syndrome. It is where infantile spasms happen. Just a fun fact. Adverse effects of ACTH. Short-term use of diagnostic use, tolerable. However, long-term use that leads to toxicity of glucocorticoids, leading to hypertension, peripheral edema, hypokalemia, emotional imbalance, increased risk of infection. Wow, that's a lot of side effects. But let's focus on this terminology here. Glucocorticoids. What is glucocorticoids, guys? Right down here, adrenocorticotropic hormone comes into adrenal cortex and produces glucocorticoids, mineralocorticoids, and androgens. We are talking about this section right here. What is an example of that particular section? Simple. It's cortisol. All right, hopefully the puzzle is pieced together. The products of adrenal cortex will be discussed in the corticosteroid hormone. Like basically, we'll talk about it in the next lecture in much detail, so don't worry about that. This lecture, we're going to focus on the functions of hypothalamus, pituitary, and thyroid. Okay, so as we now have mentioned that kidney and adrenal gland are associated, adrenal gland rests on the kidneys, left and right both. There are three sections to the adrenal gland. There's the medulla, where that's the center, right? Cortex is basically just this messenger area surrounding the medulla. And of course, the capsule, which is the protective layer, generally made out of proteins and fat. Okay, what is a negative feedback loop? We keep talking about positive feedback, but what is a negative feedback? In other words, it's inhibitory. So, number one, low blood cortisol stimulates the pituitary gland to produce ACTH. Great. Essentially, what I would like to add here is cortisol actually goes to hypothalamus and tells them that, can you produce more CRH, please? And when CRH is produced, that's when pituitary gland will end up producing ACTH. Okay? This is the base of the skull that we talked about. Sella turcica, pituitary glands here. Now, ACTH stimulates adrenal glands to produce more cortisol. Okay, so negative cortisol levels in the blood tells ACTH produce more ACTH goes to adrenal gland, and then cortisol regulation takes place. Once blood cortisol levels are sufficient, a negative feedback on the side here comes and says, oh, okay, we don't need excess. We've got enough, so please slow down the ACTH production. How beautiful is that, guys? Our body does that automatically, and we don't even know about it. Okay, so what I've attempted to do here, guys, is we tried to create our own diagrams and not take all of them from the textbooks. So it kind of helps visually remember the whole cycle. I'm going to summarize ACTH in this slide, okay? And then we'll wrap up ACTH, okay? Stress and diurnal. Diurnal meaning morning. Stimulus, okay? Positive, where? Sala tursicas pituitaris, anterior lobe only. Hypothalamus sends corticotropic releasing hormone to the anterior pituitary. Anterior pituitary sends ACTH through the bloodstream. ACTH is now landing on the adrenal gland. Adrenal gland has 3 layers: medulla, cortex, capsule. We want to focus on the cortex. Cortex produces glucocorticoids, mineralocorticoids, androgens. Now, because we're doing diagram, I'll explain here. Cortisol, famous glucocorticoid. Of course, there's more. Mineralocorticoid, we have aldosterone. I'm sure we heard about this. This is a water-retaining, kidney functioning hormone. And then androgen we already know, which is estrogen, progesterone, testosterone, and so on, right? Cortisol is our focus for this lecture. Cortisol is now released into the bloodstream and says anti-inflammatory, increases gluconeogenesis, increases protein breakdown. Perfect. When that happens, serum levels are good. Somebody needs to go and tell hypothalamus, reduce this, please, reduce this, and reduce the function of this, reducing the production of cortisol. As soon as everything is reduced and the blood volume decreases, cortisol goes back up to positive feedback loop. Hopefully that cycle is clear, you guys. Moving on to the next hormone, which is somatotropin. Soma means body, tropin means just a hormone that will act on that system. Okay, growth hormone, in other words, GH. It's a large peptide, again a protein, released, not produced, released by anterior pituitary gland, stimulated, released by growth hormone, releasing hormone. Guess where that comes from? Hypothalamus. You got it, you guys. Perfect. Inhibited by statin versions of the same. Somatostatins. It's another hypothalamic hormone. Now, why would this exist? Same reason this negative feedback exists. Whenever there is a high growth hormone, we need growth hormone inhibiting or statins. Perfect? Awesome. This is a nocturnal rhythm. Remember, this was a diurnal rhythm. This is a nocturnal rhythm. Highest levels that occur during sleep with increasing age and growth hormone reduction. Lean muscle is lost. Remember, it's growth hormone. So if it's increased, it will produce muscle. With age and growth hormone reducing with age, all of that lean muscle mass is reduced. Targets promotion of cell proliferation, muscle growth, right? And promotion of bone development. So bone and muscle. That's our growth hormone's function. Synthetic growth hormone is produced by recombinant DNA technology. This is done in vitro, outside of the body, and then injected as intramuscular and subcutaneous as what is known as a somatropins. Okay, so I'm going to say one thing over here, you guys. Somatropins, we go back all the way to ACTH synthetic version. Cosyntropin. Okay, remember the drug names, guys. They're important. Okay, moving on to the diagram here. Hypothalamus sends the releasing hormone to the anterior pituitary with a positive feedback, and growth hormone is released from anterior lobe. As always, there's growth hormone modulators, the statins, somatostatins. And these two drugs are basically the next topic in question, which is going to be the somatostatins. So let's take a look at the pharmacology of the tropins, somatotropins, just growth hormones. Majority of the growth effects are exerted directly on the target tissues such as muscles and of course bones. Minority of the growth hormone effects are mediated through somatomedins, which is basically insulin-like growth factors 1 and 2, IGF-1 and 2. Okay, now what is this? What are we talking about here? Okay, so I'll explain this very, very quick here. Growth hormone comes out of the pituitary gland, goes through 2 cycles, target tissue, or goes to the liver, pancreas. Target tissue, action occurred, done deal. But these guys, they have a stomatomedin, which is IGF, and then that goes to target tissue and acts. Okay, that's the 2 ways that growth hormone functions. So for instance, in acromegaly, what is acromegaly? It's a genetic condition defined by an enlarged body due to excess of growth hormones. So basically, it's a sister disease of gigantism. IGF and growth hormone levels are both high in this condition due to tumors that secrete growth hormones in excess amounts. So in essence, if there's a tumor in the pituitary gland that functions by releasing a high number of growth hormones, we get acromegaly. Fair enough? That's when growth hormone released by hypothalamus needs to be stopped. Okay, we'll get to that point in the next slide. Growth hormone releasing hormone is released by hypothalamus. Growth hormone released by anterior pituitary. It produces anabolic effect on the muscles, catabolic effect on adipose tissues. Okay, anabolic, catabolic. In the last lecture of diabetes, we talked about this. Anabolic is building. Catabolic is breaking. Anabolic effects build muscles. Catabolic effects break fat. So essentially, growth hormone can make you strong. You know another name for all of these growth hormones and generally hormones? It's called steroids. Guess what steroids are mostly used for in the bodybuilding world? Anabolic effect of muscles, guys. That's perfect. I'm glad we're all on the same page following. Therefore, therapeutic uses of somatotropins is in the treatment of growth hormone deficiency or growth failure in children, stunted growth. Treatment of Prader-Willi syndrome. That's exactly what this is. Children's failure in growth. Management of AIDS wasting syndrome. Anytime that you see the word wasting, wasting means muscle loss. Why? Because of AIDS. So wasting syndrome, AIDS wasting syndrome, muscle loss. In adults, it increases muscle lean mass, bone density, skin thickness, decreases fat tissues. It's almost labeled as anti-aging hormone. How perfect does that sound, right? However, it is misused as a performance enhancement drug by athletes, administered by intramuscular and subcutaneous. Somatropins, they have a short half-life, 25 minutes. In it, it triggers insulin factors. They act like growth hormones and they affect target tissue, so act like growth hormones. What's the adverse effect? It sounds all nice and good, right? But what is the sad part? There's pain at the injection site. Great, no problem. Edema, arthralgia, myalgia, flu-like symptoms. Increased risk of diabetes due to the effects by reduction in insulin sensitivity, leading to hyperinsulinemia, which is causing hyperglycemia, somatropins. Okay. Very, very simple. When there's too much of something, insulin growth factor, you become insensitive to something. if there's a lot of trauma in life, we tend to become insensitive. We develop a thick skin. Well, because there's a lot of insulin growth factor, it leads to hyperinsulinemia. According to our last lecture in diabetes, hyperinsulinemia associated with hyperglycemia. And it's, of course, the production of somatropins, synthetic steroids. But IGF acts exactly the opposite. When it does act, it acts as insulin and leads to hypoglycemia. See how it kind of plays a cyclic role, guys? And that's the whole hormonal system. And we'll get to that in detail in iodine, and I promise you it is frustratingly confusing, but we've tried to make it easy as possible. Somatropin is bad for diabetes, and IGF-1 is good as they have contrary effects. Somatropins are inhibited by somatostatins. Next hormone on the list. It binds to the receptor on pituitary, which inhibits release of growth hormones. Hypothalamus sends growth hormone releasing hormone to the pituitary's anterior lobe. Growth hormone modulators such as somatostatins, which is lanreotide and octreotide. These two are drug analogs, synthetic versions that prevent the release of growth hormone as well as TSH, thyroid stimulating hormone. They're produced and isolated from hypothalamus as small peptide normally found in neurons throughout the body, specifically stomach, intestine, and pancreas. Other inhibitors that statins focus on: insulin is inhibited, glucagon is inhibited, gastrin is inhibited. These are all pancreatic and intestinal hormones. When insulin is inhibited, there's a chance of hyperglycemia. Remember the IGF, insulin-like factor, right down here, IGF. It used to increase insulin activity. Somatostatins, these reotides we keep talking about, they will decrease insulin activity. Okay? Therapeutic uses of statins in acromegaly to reduce the growth. And then, of course, just a little fun fact here, the pegvisomant is the last resort for statins use. So far, we're just going to focus on these two drugs. In a carcinoid tumor, diarrhea and flushing, when that's happening, that's when we use these statins, somatostatins. Bleeding esophageal varices, that's when we use IV octreotide. Adverse effects of these statins: diarrhea, flatulence. Flatulence is passing of gas, nausea, and steatorrhea. Delayed gallbladder emptying and abdominal pain is seen, of course, because it is a stomach-associated hormone. Okay, next, gonadotropin releasing hormone. GnRH is released from hypothalamus, of course. Stimulates the secretion of gonadotropins. It's another type of a hormone, which is follicle stimulating hormone or follicular stimulating hormone, FSH, luteinizing hormone, LH. Although long-term administration of gonadotropin releasing hormone will inhibit FSH and LH, they will come to down-regulating growth gonadotropin releasing hormones, guys. Okay, this is confusing, right? Because GnRH will do what? It will release positively FSH, LH. Great. Then why does it have a negative effect? It's about duration of use. So long-term administration will actually inhibit. That brings us to the attention here in the previous lecture, or previous slide, sorry, is when IGF it acts like insulin, but then there's insulin sensitivity reduction that causes hyperglycemia. So why is it opposite? Well, it's cyclical, guys. It's cyclical. Okay. Gonadotropin releasing hormone drug analogs are histrelin, naphrelin, cosrelin. Functions of these gonadotropins, long-term use only, suppress the production of gonadotropins, right? Negative, right here. That's the actual therapeutic use, using them for a long term. Reduction of production of gonadal-steroid hormones as well. It reduces androgen and estrogen production as well, because it has to do with our reproductive system. Therapeutic uses of the gonadotropin-releasing hormones. Treatment of prostate cancer. Why? Because prostate cancer shoots out the lack of testosterone. Okay? Gonadotropin releasing hormone will end up increasing it, treating prostate cancer. Endometriosis, premature puberty. These are all treatments done by GnRH. Adverse effects, and of course, remember these are long-term, right? Adverse effects, hot flushes, sweating, diminished libido, depression, ovarian cysts in the females, also known as PCOS, polycystic ovarian syndrome or disease, rise in testosterone, bone pain, hot flushes, edema, gynecomastia. This is all in the males. It's contraindicated in pregnancy and breastfeeding mothers. So, hypothalamus, gonadotropin releasing hormone. Negative feedback done by modulators of FSH and LH. All the relins. And of course, leuropride. Anterior lobe does not produce FSH, LH, and does not produce androgens. Perfect. Moving on, actual gonadotropins. The last slide was gonadotropic releasing hormone. This is actual hormones, which is follicle stimulating hormone, luteinizing hormone. They're produced as glycoproteins in the anterior pituitary itself. Functions as a regulator of androgens and estrogen, which is gonadal steroid hormones. It functions as that. Hence, it's used in the treatment of infertility. Essentially, it increases fertility. Menotropins, human menopausal gonadotropin hormone, HMG. This is obtained from postmenopausal women, contains both FSH and LH. Then there's another drug. So now we're moving into the drugs, right? We're moving to synthetic drugs that act as gonadotropins. We have urofolitropin, FSH, folly. Of postmenopausal women, there's no LH content. So menotropin has both. Urofolitropin has just FSH. Folitropin alpha and beta, again, synthetically manufactured FSH. Which technology? Recombinant DNA, perfect. Human chorionic gonadotropin, remember this was the pregnancy marker. Placental hormone and the marker for pregnancy goes up as the baby grows inside the womb. Effects are the same as LH, it luteinizes. Then therapeutic uses of HCG and FSH products, which is all right here. What is the therapeutic use? You give it by IM or SC administration for up to 5 to 12 days, and it leads to a ovarian follicular growth. And of course, then it will lead to ovulation, hence fertility treated. Adverse effects, ovarian hyperstimulation syndrome, and that can be life-threatening, guys. So dose modulation is very, very important. So this is the diagram from our references. GnRH released from hypothalamus. Hypothalamus goes to the anterior pituitary. Anterior pituitary releases FH and LH, and FSH will both go to ovaries, and then of course testes. LH and FSH trigger testosterone production in the testes, estrogen production in the ovaries. Estrogen production in the ovaries is female secondary sex characteristics such as breast growth, hip broadening, and pubic hair growth. as well as folliculogenesis, hence fertility. Okay, so the story of this is hopefully clear to you guys. Lastly, testosterone is the effect of sex hormone on men. Penis and scrotum growth, facial hair growth, larynx, lowering of the voice, so your voice becoming deeper and deeper, as if we've gone from adolescents to adults. Okay, shoulders broaden, body, armpit, pubic hair growth, and muscular increase body wide. Also causes spermatogenesis. That also is fertility, guys. Okay, when all of that is done, GnRH triggers the anterior pituitary. We've been through that. Oh, and number 5, before puberty, the hypothalamus and pituitary are very sensitive to negative feedback signals from testosterone and estrogen. So they can also go back up the stream with a negative feedback. During puberty, the sensitivity of the hypothalamus and pituitary gland to this negative feedback decreases. Why? Because we need more growth during puberty, guys. We need all of this during puberty. This changes, allowing an increase in production of testosterone and estrogen, stimulating development of secondary sex characteristics. And that's the full story of gonadotropins. One more revision of our diagrams. Hypothalamus, hypothalamus, anterior pituitary, GnRH, GnRH. Perfect. Releases FSH, goes to ovaries and testes, produces estrogen, progesterone, testosterone, also known as gonadal steroid hormones. FSH are gonadotropins. Synthetically speaking, we have minotropin, urofolitropin, alpha-beta folitropin, and HCG. Fair enough? This is all stimulating. What about inhibiting? FSH normally goes, and all of these pathways are, blocked. We already talked about them. But why? Because of long-term use of gonadotropin releasing hormones, oversaturation of the anterior pituitary done by leuprolide, goserelin, naphthalin, and hysterelin. Perfect. So far so clear, guys? Great. Now we're on to the prolactin, the next hormone on the list. Peptide hormone, again, a peptide secreted by the anterior pituitary. Great. Functions to stimulate and maintain lactation. Other function? It reduces the sexual drive and reproductive function. It's just when you have a baby, right after the baby, you're feeding the baby. Your body's like, okay, let's wait till you have a second baby. I'm going to reduce the sexual drive and all the reproductive functions as well. Inhibition of prolactin, which means when lactation needs to be inhibited, we give dopamine, or natural dopamine. But if it's a synthetic, we need to make one that binds to D2. So it's a D2 agonist, such as bromocriptine and cabergoline. Stimulation of prolactin, when nursing mothers are not producing enough, we need to stimulate lactation. That's going to work as dopamine antagonist. Fair enough? Such as metoclopramide, risperidone, and sulpiride. These drugs will produce increase in prolactin, along with physical stimulation, such as if a baby wants milk, they will stimulate nipple by suckling. That will produce a positive feedback mechanism to prolactin into the breast, where the growth of mammary glands are induced and lactation is produced, and of course a positive feedback loop continues until dopamine comes into play and produces lack of prolactin. Okay. Therapeutic uses of D2 agonists. Hyperprolactinemia from galactorrhea and hypogonadism. These two are conditions that reduce our control on prolactin release. All it does is starts producing extreme amounts of prolactin. Okay. Pituitary microadenomas it's a tumor that produces excess of prolactin. Type 2 diabetes mellitus, bromocriptine can be used as well. Adverse effects, nausea, headache, and psychiatric problems. Over here, you notice that prolactin is stimulated not only by low dopamine or by the prolactin dopamine antagonist right here, these drugs, but it's actually slightly affected by the thyroid releasing hormone. That's pretty strange because thyroid goes to thyroid gland. Then what does it have to do with prolactin? Well, endocrine system is slightly overlapped with one another. The reason why I introduced this here, even though it's slightly insignificant, is because we will be talking about this in the second half of the lecture. Amazing. Posterior pituitary hormone. So far we've finished talking about anterior pituitary and we stopped talking about hypothalamus. Now, posterior pituitary hormones. So right here now, there's only two, nice and easy. Unlike the anterior pituitary, the posterior pituitary hormones that are produced in hypothalamus itself, there's no releasing hormone. It's a direct communication. So oxytocin comes out of here and here itself just as is. It's like a bus stop where you don't have to change buses. Vasopressin is the same thing as well. There's two drugs. Vasopressin, also known as ADH, anti-diuretic hormone, and oxytocin. These hormones are produced in and transported from hypothalamus to posterior lobe of the pituitary gland and then sent unchanged into the bloodstream. This stimulation of posterior pituitary hormones is done by high plasma osmolarity and blood pressure. Blood pressure changes and plasma osmolarity changes. They stimulate the brain and say, oh, okay, I need more vasopressin. Vasopressin goes out and affects the target tissue to control plasma osmolarity and blood pressure. Both oxytocin and vasopressin is administered either IV or SC and have a short half-life as well. So let's talk about it in a slight bit of a detail. Oxytocin and vasopressin, also known as antidiuretic hormone. Oxytocin's mechanism is an obstetrics pharmacology. Stimulates uterine muscle for contraction, so during labor induction. Milk ejection in the breast is also in effect caused by oxytocin because of myoepithelial cell contractions in the mammary alveoli. Adverse effects: hypertension, uterine rupture, water retention, and fetal death. Now these are extremes, guys. Vasopressin, antidiuretic hormone. It's a vasoconstrictive hormone. It binds to a V2 receptor in the kidneys collecting tubules. You guys remember we had a nephron, and the nephron would go into this one entire loop, descending loop, ascending loop, and then plateaued, and then of course the collecting ducts, right? And then urine comes out. Well, collecting duct is right here. There, it increases water permeability and water reabsorption. So H2O comes back into the bloodstream. Water retention. We know what that does? It increases blood volume. Volume increases blood pressure. Therefore, is a vasoconstrictive property. Fair enough? And it's also known as antidiuretic, same reason. Diuretic means water leaves in the urine. Antidiuretic means water comes back into the bloodstream. Okay. Treatment of diabetes insipidus, we can use vasopressin. Management of cardiac arrest, we can use vasopressin. Controls bleeding, esophageal varices, as well as treatment of nocturnal enuresis. So wet beds, basically. When the V1 receptor in the vascular smooth muscle is activated, then it causes vascular smooth muscle constriction. Vascular constriction. Analog, which is the drug, is desmopressin, and it's a long-acting drug. What's the adverse effect of vasopressin or desmopressin? Water intoxication, hyponatremia, abdominal pain, tremor, vertigo, local irritation for desmopressin administration when it's done via nasal spray. It's just a reported side effect. And of course, so far, all of these hormones, the pituitary hormones, hypothalamic hormones that we talked about, are in this reference here. Please pause this video here. I won't scratch the screen just yet. Pause the video here. You could write the summary. This is from our reference as well. But so far we talked about somatostatins, growth hormone antagonist, gonadotropin FSH, gonadotropin LH, gonadotropin releasing hormone. Gonadotropin releasing hormone antagonist is also another category here. Dopamine agonist. Why do we need dopamine agonist? Well, it plays a role in the prolactin cycle. Oxytocin receptor antagonist. So when you want to prevent uterine contraction. And lastly, vasopressin family as well. Okay. All right, guys. Thyroid gland and hormones. You guys did good. Hypothalamus and pituitary is done. Now we're into thyroid. Thyroid gland is an endocrine apparatus that facilitates two things: normal growth and maturation of the body, and maintains a level of metabolism in the tissue, so in the gut. Two major thyroid hormones: triiodothyronine, which is T3, most active form, thyroxine, which is T4, and it roams around in the blood before it turns into T3 and then acts. All right, perfect. Decreased secretion of T3 and T4, called as hypothyroidism. Fair enough. Increased secretion of T3, T4, hyperthyroidism. Perfect. What does hypothyroidism do? And what does hyperthyroidism do? Okay, before I get into this list here, I'm just going to mention one thing. Hypo is low, right? Hyper is high. That's exactly what it does. Hypothyroidism reduces everything in the body. Hyperthyroidism increases everything in the body. Let's see what though. Hypothyroidism, bradycardia, poor retention to cold, weight gain, which is lack of basal metabolic rate. Therefore, no metabolism, weight gain happens. Mental, physical, slowing, retardation, dwarfism, growth is stunted, decreased basal metabolic rate and decreased GI activity, therefore weight gain. Everything is low. Exact opposite is true for hyperthyroidism. Tachycardia, cardiac arrhythmias, body wasting, remember muscle loss, heat intolerance, increase in temperature of the body, tremors, so hypermovements, nervousness, weight loss because of increased in basal metabolic rate, increased in GI activity. Everything is a high. Okay, amazing. So now I'm going to introduce something you're not going to like, but apologies, it's a very important content of today's lecture. It's a warning, okay? Iodine works mysteriously and at times inversely to its own purpose. So please bear with us when we're talking about iodine. Mechanism is actually fully not understood yet by the scientists as well. But what we know, we've tried to depict in the most comprehensive manner. So stay with us here, you guys. The T3 has 59% iodine content and T4 has 65. What does that mean? Thyroid is useless without iodine. But mechanism is fully not understood. So let's take a look at what we can rectify. Biosynthesis of thyroid hormone. How is thyroid hormone actually produced? Well, let's take a look. Thyroid gland is composed of multiple follicles made up of single layer epithelial cells. Perfect. Surrounded by a lumen filled with what is known as a thyroglobulin. Okay, what is thyroglobulin? Thyroglobulin is storage. It's a storage form of thyroid hormone. So if T3, T4 are produced, they are filled inside thyroglobulin. Thyroglobulin is in a lumen, inside the lumen. In it, we have epithelial cells, single layer. This is multiple follicles. Okay. Thyroglobulin, once stimulated by whatever the stimulus is, releases T4 onto this cleft, and outside of the cell into the bloodstream. Okay. TSH is the thyroid stimulating hormone. T4, T3 regulating hormone, also known as thyrotropins, produced in anterior pituitary in response to thyroid releasing hormone. Thyroid releasing hormone is also known as thyrotropin releasing hormone. It's a TSH regulating hormone, and it's produced in the hypothalamus. So hypothalamus sends out thyroid releasing hormone. Thyroid releasing hormone goes to pituitary, specifically anterior pituitary, and then thyroid stimulating hormone goes to the thyroid gland. Thyroid gland has thyroglobulins. They get affected by TSH, and then of course T3 and T4 are released. This is actually the physiological releasing mechanism. But how is it actually produced? How do you make T3 and T4 and then store it? Let's see. TSH activity is mediated by CAMP, cyclic adeno monophosphate activity. It's a more of a stimulant. TSH also leads to stimulation of iodide uptake by thyroid gland. Okay, so let me erase everything off the screen here, guys. And let's talk about this. TSH affects iodide uptake by thyroid gland. Iodide uptake by thyroid gland. Okay, now what? Iodide, which is I negative, gets oxidized into iodide I2 by peroxidase enzyme. Okay, so iodide goes into I2 by a peroxidase, sorry. Okay, so far so clear? Perfect. Tyrosine on thyroglobulins go through iodination, and it creates monoiodotyrosine or diiodotyrosine. Two things are created. Okay, so this I2 touches the walls of the thyroglobulin and affects tyrosine. Okay, so I2 plus tyrosine, perfect. That equals monoiodotyrosine, diiodotyrosine. So far so clear? Okay. Condensation of 2-diiodotyrosine makes T4s. So 2 times DIT equals T4. Okay. Condensation of 1 monoiodotyrosine with 1 diiodotyrosine makes T3. Okay, so 1 MIT times 1 DIT equals T3. Okay, let me write that down again. 2 DIT equals T4. 1 MIT plus 1 DIT equals T3. Proteolytic cleavage of thyroglobulins, basically opening the doors, will then store these two inside of thyroglobulin. And then it releases thyroid hormones into the bloodstream based on TSH activity. Hopefully that whole mechanism is clear, you guys. If not, please do pause and ask questions in the comments and we'll be sure to reply. Okay, so let's take a look at the diagram here. There is some stimulants and then there's some inhibitions. Cold, acute psychosis, and the circadian cycle, which is a diurnal, nocturnal, pulsatile rhythm. These are all positives, okay? But severe stress is an inhibitory stimulant. It says severe stress is going to stop the production of all of the following steps. In the hypothalamus, there is TRH, thyroid releasing hormone, goes to anterior pituitary, and there is thyroid stimulating hormone goes to thyroid. Okay, thyroid positively says, iodide, please come inside, and then we'll go through oxidation with by peroxidase into iodide, I2. I2 will go ahead and meet with tyrosines located on the thyroglobulins through iodination process, create MIT-DIT. 2-DIT is T4, 1-MIT, 1-DIT is T3, and then of course storage. Very normal, okay? Everything is good so far. Now, there is a somatostatin and corticoids or dopamine as an inhibitory mechanism to the anterior pituitary. Okay, that will prevent this cycle. We know that, which will prevent iodide uptake, which will prevent release of T3 and T4. Okay. Another thing is T3 and T4, increased concentrations in the bloodstream, also become a negative feedback loop on both hypothalamus and anterior pituitary themselves, and says, sorry, I don't need a lot more TSH, please reduce it. And lastly, iodide can also have a negative feedback loop. Remember when we said iodide is tricky? Well, look here, it has both on thyroid itself. So let's see how that works. This is another reference that we found where normally, because of a stimulant, transport of iodide goes into the thyroid gland. This is normally a TSH. And of course, we've already had TRH, TSH into thyroid gland, I2 peroxidase into I2. Iodide will oxidize into I2, which is iodine. And then organification, also basically just another word of saying that it iodinizes itself. On the thyroglobulin, it converts into MIT-DIT, which then moves into T3, T4, proteolyzes itself, and T3, T4 comes into the blood. Peripheral tissues get affected by T4, T3. Remember, T3 is an active molecule. T4 needs to turn into T3 in order to act. Okay. Iodides here, externally administered iodides, will prevent this release of T4, T3 as well. Also, radio contrast medias, beta blockers, corticosteroids, amiodarone, these will prevent the use of T3, T4. Okay, so this is inhibit use. This is inhibit release of T3, T4, of T3, T4. Okay. Another reference from another textbook. Plasma, thyroid cell, colloid, which is inside the actual lumen itself. So in plasma, what do we need is T3 and T4. Well, how do we get it? Iodide uptake into the thyroid cell. Iodide turns into I2 by peroxidase enzyme. Peroxidase enzyme producing this active iodide, I2. Iodination takes place inside the thyroglobulin's walls where tyrosine is located. Tyrosine will become a DIT, MIT once it clubs with the iodine. Condensation will take place, and of course proteolytic release by the hormone will take place, and bloodstream will have a T3 and T4. Now, important thing here, these guys that are in negatives. At different steps, anti-thyroid drugs, so basically a drug that is used in the thyroid, which is hyper. Fair enough? Perfect. Propylthiouracil, methimazole, elevated administration of iodide. All of these are basic treatments of hyperthyroidism. Fair and simple. Next, this is very important. I keep bringing this back because it's extremely important. It is a disclaimer, okay? Iodine deficiency leads to hypothyroidism because iodine is necessary for production of T4, T3. That's perfect. It makes sense. But for some mechanism of action, iodine deficiency also leads to hyperthyroidism as the thyroid gland increases the production of T3, T4. This is due to hyperstimulation of TSH to compensate for the lack of iodine. Iodine, when it normally produces T3, T4 and it stops because there's a deficiency of iodine, that's when the thyroid gland is like, okay, so what do I need? I need a T4, T3 dose, but I don't have iodine. So what am I going to do? I'm going to go up and stimulate the hypothalamus directly and say, I need more TRH. After TRH, more TSH. After TSH, I need T4, T3. Great. I don't care if iodine is deficient. I made myself T3, T4. But here's the twist. When that happens, the thyroid gland becomes hyperstimulated and it produces a swelling. Can we guess what a swelling in hyperthyroidism is called? It's a goiter. And that's where the goiter comes from. Okay, moving on from the confusing iodine. Okay, thyroid hormones. Let's talk about pharmacology, guys. Mechanism of action and pharmacokinetics. Mechanism action. T3, T4 are bounded to thyroxine binding globulin in plasma. So now what we've done so far is we have crossed this whole cycle and we have come back to plasma, now talking about T3, T4. It is bound to thyroxine binding globulin, TBG. This, ladies and gentlemen, is taxi. Because T3, T4 enters the bloodstream near the thyroid gland, and if it needs to go to, say, for example, kidneys, it's going to fetch a ride, right? What is that ride? This is terrible kidney, by the way. That is not how we're writing kidneys, okay, guys? I need to improve my handwriting. Okay, apologies. So this is it. Kidney, look at that beautiful kidney. Okay, so T3, T4 takes the taxi to kidney. In order to have raw T3, T4 enter into a target cell, it must dislodge itself from this globulin, so detaxi. In target cells, T4 is deiodinated to T3. Remember, T3 is the most activated of the two. So it becomes deiodinated and then one charge is dropped and now it's become T3. T3 then enters the nucleus of the cell, attaches to a specific receptor and promotes RNA synthesis. Subsequently, there is protein synthesis that takes place. So DNA makes protein. These proteins are actually what are responsible for the physiologic effects caused by T4 in the body. Wow, what a long journey from TRH all the way to these proteins that cause effect in the bodies. Hopefully that journey is perfectly clear, guys. Pharmacokinetics, T3, T4 are well absorbed orally, so this drug you can take as a tablet. Food and calcium and aluminum, antacids, they've reduced the T4 absorption. So try not taking thyroid with food and calcium. So don't take it with milk, essentially. Okay, metabolism takes place in the liver via conjugation mechanism, so first pass metabolism. Deiodination is also a major route of metabolism for T4. Why? Because T4 is digested and T3 is produced. By what process? By deiodination. Excreted in the bile. The drug-induced hepatic metabolism by other drugs, remember, this is metabolized in the liver. Therefore, other drugs that are induced hepatic metabolism, such as rifampin, phenobarbital, carbamazepine, phenytoin, etc., will induce the metabolism of T3, T4, which means it will excrete faster. Reduces its effects in the blood. Okay, so here's the picture to depict that pharmacokinetic. Phenytoin sodium, phenobarbital, rifampin will cause enzyme induction of CYP 450. When T3, T4 arrive to get metabolized by the P450 family, inactive metabolites are formed, and then they just excrete unaffected. Therefore, it's important to understand this drug-drug interaction, and we have a full lecture on that, you guys. Please do check it out. It's called Drug Interactions, and then there's General Pharmacology as well to understand liver pharmacokinetics and liver metabolism and so on. Okay, characteristics of T3 and T4. T4 is produced less than T3, almost 20%. Then we need to understand one couple of things here, that the daily production of T3 is generally less than T4. Why? Because T4, in order to be activated, will get de-iodinized into T3. So it's important to have more T4. Metabolic clearance, T4 is cleared by 1.1 liters, obviously it's less. T3 is cleared by 24 liters per day. What we need to know here is that amount of bounding is the same because they both taxi together from thyroid gland to target tissues. Biologic potency, 1 and 4. Obviously, if T3 is more active, T4 needs to convert to T3. These are just some values from our references, guys. Now we're moving into the diseases. Hypothyroidism, what is it? Hypothyroidism. It is autoimmune destruction of thyroid gland or the peroxidase enzyme itself. It is diagnosed by elevated TSH levels. Unused TSH not converting into iodine into T3, T4. So remember, thyroglobulin, and then it's supposed to release T3 and T4. Why? Because TSH said so. If there is a lot of TSH, which is not being converted to T3, T4, right here is the problem. Now, what was there? There were two things there. There was DIT-MIT conversion, and most importantly, there was peroxidase conversion of iodine into I2. Right? Imagine if all of this didn't exist. Well, then T3, T4 doesn't exist. And then the drugs used for the treatment of the same process, we have levothyroxine T4, which is a preferred mechanism. Liothyronine is T3, not preferred as much because it gets digested really, really fast. And then Leotrix is a combo of T3, T4, is better tolerated than levothyroxine, but let's just stick to levothyroxine for our therapeutic purposes. Dosage of levothyroxine, once daily for 6 to 8 weeks to regulate thyroid hormones. For hypothyroidism, toxicity of levothyroxine is directly related to T4 levels, and it manifests as hypothyroidism emergency. It is nervousness, palpitations, tachycardia, heat intolerance, weight loss, basically T4 toxicity. So what is this trying to say? Is that when there's hypothyroidism, we offer T4, and if T4s rise so much that there's toxicity, what will that look like? Hyper. So hyperthyroidism symptoms are the actual toxicity manifestations of T4, which is levothyroxine, in the treatment of hypothyroidism. Fair enough? Metabolic induction of levothyroxine is done by CYP 450. Mediated metabolism. Right here, you guys. Drugs like phenytoin, rifampin, barbs will accelerate this thyroid metabolism, reducing its effect in the body. So that's how dose modulation needs to take place. Moving on, treatment of hyperthyroidism. Also a Graves' disease, which is an autoimmune disease of the thyroid gland, where it's the most common cause of hyperthyroidism. How? It's diagnosed by a reduced level of TSH levels due to high circulating T4, T3. Okay, let's break this down here, you guys. a T4 and a T3 concentration increase in the blood will lead to what, guys? So let's take a look here. We'll go back. We're going to go back. Increased in T4 and T3 will have a negative feedback to both pituitary and hypothalamus. So this will have a negative feedback to reduce TSH. Okay, this is an indication that there is hyperthyroidism. Negative feedback loop stimulates the decrease in the TRH and TSH production, causing Graves' disease. A goiter is produced in response to hyperactivity of the thyroid gland. How did this happen? How did T4, T3 come to play? Because of hyperactivity of the thyroid gland. That leads to a swelling in the neck. That is goiter. Looks like this. Enlarged thyroid gland instead of the normal thyroid gland. Iodine is used to make T3, T4. Iodine deficiency in diet leads to thyroid getting larger to capture as much as iodine possible to make use of it and make as much as T4, T3 needed. So goiter happens. This panic from the thyroid gland leads to irregular cell growth. Look at that, how irregular this is in the thyroid follicles. Hence, it causes gland to swell, and that's what goiter is. Treatment goals: we want to remove a part of the gland or the entire gland at all, and then put people on drugs all life. Inhibition of the synthesis of T3, T4, inhibition of the release of the T3, T4. Okay, let's talk about treatment of thyrotoxicosis, another word of saying hyperthyroidism. The removal of the whole gland or just a portion of the gland is a surgical modality, or a radioactive destruction using iodine-131. It is uptaken by thyroid follicular cells. Most patients turn to hypothyroidism because of this treatment, because you're just reducing so much, right? You're destroying the gland, you're removing the gland, you're radioactively affecting the destruction of the cells using iodine-131. Therefore, levothyroxine can be used to counter this refractory mechanism. Remember, everything in hormones is cyclical, guys. Inhibition of T3 and T4. That's the second modality. Well, thioamides, propylthiouracil, also known as PTU, or methimazole are the three drugs in this class that we will talk about. They inhibit both oxidation process for iodination of the tyrosyl as well as the condensation of iodotyrosine. So what does this statement mean? It means that when thyroglobulin has tyrosines, they get iodinized, right? Oxidation happens between them. They get iodinized to form MIT-DIT. Okay? This is stopped. That's number one. Second is when there's a release of the already existing T4, T3 inside the storage, all you gotta do is add more inhibition. It prevents the condensation. So condensation is opening of the channels to reduce T3, T4. So we produce inhibition over there. So basically, oxidation, condensation is blocked. Therefore, T3, T4 are not formed. No MIT, no DIT. PTU blocks the peripheral conversion of T4 to T3, as well as there is no effect on thyroglobulin storage of T3, T4, which means any T4 or T3 inside the globulin already located, there's no effect on it. So there must be a delay, since PTU waits for T4 to come out and then acts on it, right? It needs to come out. So we need to delay this secretion. PTU is used during first trimester of pregnancy because it has low teratogenic properties. Methimazole is preferred otherwise because it has a longer half-life, therefore dosage modulation can be done easily. PTU has been responsible for hepatotoxicity and rarely some agranulocytosis. Fair enough? Amazing. Inhibition of T3, T4 release, right? So what do we do here? We talked about removal of the gland. We talked about the synthesis problem. But remember this section right here where T4, T3 is still in the globulin? It's going to come out. And only then PTU can act on it. So we need to delay this. That's where this comes into play, the release. Pharmacological dose of iodide will inhibit the iodination of tyrosines by blocking peroxidase enzyme temporarily. This is known as the Wolff-Chaikoff effect. Just a fun fact. Elevated iodide tends to inhibit the release of T3 and T4 from the thyroglobulin and keeps it in the storage as unusable towards the systemic circulation. Elevated iodine also decreases vascularity of the thyroid gland, therefore decreasing the effects. Treatment of thyroid storm, of course the next slide right here. It's administered orally. Duration of action is few weeks only. Adverse effects of iodine, elevated iodine. Sore mouth, sore throat, swelling of the tongue, swelling of the larynx, rashes, ulcerations, metallic taste is all iodine side effects. Okay, all of this is well explained back in this chart here. So I'll take you guys back to this chart. I will erase everything on the slide here so we can see better. Propylthiouracil prevents tyrosine on thyroglobulin from being oxidized. There is iodination and condensation also blocked by propylthiouracil. Iodide elevated levels will prevent the same process. Iodide levels will prevent the release of T3, T4 into the bloodstream as well. So this chart explains the act of all the drugs that we just talked about, guys. Okay, and then let's finally just talk about thyroid storm. Thyroid storm is extreme thyrotoxicosis, hyperthyroidism. Treatment is elevating iodide, like we explained above. It blocks two different locations. Drugs are given in higher dose, of course. Other beta blockers such as metoprolol, propranolol are also used to reduce the sympathetic stimulation from hyperthyroidism. Remember, hyperthyroidism is where everything increases, including cardiovascular effects. Tachycardia, for example. High blood pressure, for example. High blood volume, cardiac output. All of that is increased. Therefore, beta blockers can be used as an adjunct in the therapy of thyroid storm. Lastly, hyperthyroidism, thyrotoxicosis, or hypothyroidism. How do they affect different systems? This chart very well explains it. Let's talk about a couple of things here. In the central nervous system, hyperthyroidism causes nervousness, hyperkinesia, emotional liability, and agitation. Whereas hypothyroidism causes lethargy, fatigue, slowing of the mental process, weakness, muscle cramp, right? Everything is low. Metabolically speaking, hyperthyroidism causes increase in basal metabolic rate, negative nitrogen balance, hyperglycemia, increase in free fatty acids, increase in hormone degradation, increase or decrease in cholesterol, and decrease in triglycerides as well, increase in requirements for fat, water-soluble vitamins, increase in drug metabolism, and then of course decrease in warfarin requirement because it's already anticoagulant, right? Anticoagulant means increasing in bleeding, but it already increases everything. Hypothyroidism, on the other hand, will have a decreased metabolic rate, where therefore it's less metabolism. And because of less metabolism, there is decrease in weight control. So I'll rewrite this here. It is basically just going to be weight gain. If there is lack of metabolism, there's going to be weight gain. And then let's take a look at the cardiovascular system. In hyperthyroidism, there's increase in heart rate, increase in stroke volume, increase in cardiac output, pulse pressure increases, high output of heart failure, increased inotropic and chronotropic effects, arrhythmia, angina, so on and so forth. Or exact opposite for hypothyroidism. There is decrease in heart rate, stroke volume, cardiac output, pulse pressure, everything is low, right? All the bradycardia, prolonged ECG, so on and face. Now, all of these you can write down as little pointers and make a short note on it, you guys. So I'll erase everything off of here. So this is a very, very important summary for hyperthyroidism and hypothyroidism. Remember, everything is high for hyper and low for hypo. Okay, guys? And of course, this is the last summary that we usually give out as a slide. This is a hypothalamus with anterior pituitary. And of course, there's posterior pituitary as well in the green here. So hypothalamus, neurosecretory cells will secrete releasing hormones into the posterior or anterior pituitary. The posterior pituitary in this picture releases hormones into the bloodstream. This is oxytocin and antidiuretic, which is vasopressin, goes to uterine as mammary glands, and then ADH goes to kidneys. Great. This is anterior pituitary. We talked about how the hypothalamus sends messages to the anterior pituitary. And these are known as releasing hormones. And then the rest of them will be known as stimulating hormones. So TSH, ACTH, FSH, LH, GH, prolactin, endorphins. All of these have different locations where they function. And all of these drugs here are either endogenous or exogenous hypothalamus, pituitary, and thyroid hormones. These are our references for today's lectures, you guys. And hopefully you guys enjoyed today's lecture. If you have any questions, please leave them in the comments below. We thank you for watching. And please visit our website if you're interested in coaching. If you'd like to learn one-on-one, we offer lectures as well as dental consultation with myself, Dr. Rishi Shah, over Zoom meeting. Please do check out the link below in the description box to visit our website. Thank you for watching and have a great day.